Greetings. So today, in this video, let's talk about the anti-gout drugs. Now, when we cover gout and pseudo-gout in pathology diseases, we will go through some more medications that are used for gout and treatment of gout. That belong to other categories, but there's some drugs that are very, very specific to gout and uric acid, regardless, uh, um, of the classification. So that's why this is an area where if it's gout specific, it doesn't neatly fit into other classifications from a physiological perspective. I've collected them here. And again, these are basically uric acid drugs. Because remember, gout is caused by increased uric acid. And so these drugs, in some way, shape, or form, help us aid with gout, and they may help us with the uric acid levels as well. So again, when we talk about gout, we're going to talk about a couple of things with gout. Uh, so why is it an issue? Well, gout is painful, and these patients have pain. And what happens is you have these attacks of acute pain, and these are acute episodes. And in between, you have times when you don't have these acute painful attacks. So uh, there's medication for when somebody's having an acute episode or an acute attack. And then there are medications that prevent the acute attack from happening. Okay. So the goal of the acute attack is to manage pain. The goal of the medications, other than when it's used for acute attack, is to prevent the acute attack from happening. Okay. So let's classify these drugs this way, which is with anti-gout drugs, you classify them as treatments for acute episode, and that's classification one. Classification two is drugs that are used to prevent acute attacks, and then we'll study them. So let's look at drugs that are used during acute attack or during an acute episode of gouty arthritis. And the good news is there's one, colchicine. Okay, so what happens? So during a gouty attack or attack of gout, you have these urate crystals. Okay, and these crystals migrate to the joints and they precipitate. And and what happens is you have your white blood cells, leukocytes that come in, and they look at this as a toxin. So they mount an immune response and they mount an inflammatory response. So what's the hallmark symptoms of uh, inflammation? So you would have swelling, right? Heat, pain, vasodilation, right? Remember we covered all of this with anatomy and physiology of inflammation, so that's what you get to see, right? Now, what if a medication could decrease the migration of leukocytes or white blood cells into this joint? So as WBCs are trying to get in, we're going to stop them. And as they're trying to eat up these urate crystals, because remember, phagocytosis is one of our immune mechanisms, it prevents it from doing so. Well, that means there's going to be less immune response mounted or less inflammation. Well, that's how colchicine works. Okay, that is how colchicine works. Okay, so again, used for acute treatment of acute gout. Acute. Treatment of acute gout is what it's used for. Okay, acute gout attack. How do I know it's working? Well, it's given for acute attack, and the issue with the acute attack is what? Pain. So, how do I know this drug is working? The pain will start to get better. Decrease of pain. So, what would I do? Assess them for pain. See, easy. It's too many things to learn otherwise, right? Drug, how does it work? What is it used for? How do I know it's working? Easy, okay? What are some of the side effects? So, I'll give you the most important ones as I promised, ones that you need to know. GI distress, diarrhea, okay? And as promised, I'll give you interventions for the side effects. What would you do? So again, if they are having lots of diarrhea, we notify the provider, and the provider may choose to order an antidiarrheal. If the diarrhea persists, it may be severe enough and the provider may choose to stop it. It may also cause bone marrow suppression and decrease platelet count. What do we do? Well, if the bone marrow is suppressed, there may be decreased WBC count. Hey, we gotta monitor for infection. What else if the platelets are down? Platelets help us coagulate blood. So if low platelets means less coagulation, meaning the person may bleed. So we monitor the patient for signs and symptoms of bleeding. Additionally, a more um, quantitative measure for bone marrow function and platelets would be monitoring complete blood count to check the levels of different cells in the blood. Okay, so those are three interventions. Again, uh, these are interventions that we do, when they're ordered by the provider, and we we monitor and keep an eye on them. Last but not the least, hepatic liver necrosis, death of the liver. And again, we monitor some of the labs that are related to the liver function. Okay. Again, usually patients will come in if that be the case, and there may be pain in the right upper quadrant and some of the other liver symptoms, um, such as jaundice and those kinds of things. So again, the patient will have a unique have a specific presentation of something livery going on, and then we go from there. Okay. So that would be the acute treatment of acute gout, colchicine. Oh, it's hurting right now. Now let's say it's not hurting right now. Okay. So what drugs do we give to the patient when it's not hurting them acutely at this time? And these are medications that are used in the chronic phase of gout, where they are not having an acute attack. The goal is to prevent the acute attack from happening. So, why does gout happen? Well, it's because of increased uric acid, which gets deposited in their joints. So, the goal of prevention is to decrease the uric acid, which would lead to decrease of the acute attacks. Easy, right? Telling you. If it makes sense, you have to learn very few things, and you can actually apply those very few things in a variety of situations. Tests, right? Real life, absolutely. Okay. So now that our goal is decreased production of uric acid, okay? Sorry, so our goal is decreasing uric acid, right? So what are two ways we can decrease uric acid? Well, way one, we can decrease the production of uric acid. Well, what do you mean? Remember, purines get converted to uric acid through an enzyme, xanthine oxidase, right? So what if I have a drug that prevents xanthine oxidase in the liver from working? Like I said, if you're not sure about this, I have an anatomy physiology video on this. Take a peek at it where I discuss this. So again, if I prevent xanthine oxidase from working, purines will not become uric acid, so uric acid levels will not go up. Okay, that will decrease production of uric acid. Do I have a medication that does that? Yes, sirree, Bob. It's allopurinol. Okay, we've talked about how it works. What is it used for? Chronic management of gout. Well, how do I know it's working? Okay, so it decreases the uric acid. So I can, if a provider orders blood test, I can check their uric acid in the blood, right? What else? Well, I'm giving this to prevent acute attacks. I check the number of acute attacks. If they're going down, guess what? The med is working. See? Simple. From anatomy, physiology, pathology, pharmacology. All of this lines up beautifully. If you understand anatomy, physiology, and some basic stuff about the disease, everything else just locks and loads into the place. If you see, that's exactly what I have. Decreased gout attacks and decreased uric acid levels in the blood. Easy, telling you. Medicine, healthcare can be very, very easy, provided it's done right. Okay? Okay, what are some of the side effects? Okay, so there's three big ones that we are going to look at. One is hypersensitivity. So remember when you have an allergic reaction, fever, rash. So those are some of the things that one can have with this drug. Again, we call the provider, notify them. The provider may stop the drug and may order corticosteroids or some medications for the hypersensitivity. May cause kidney injury. So what do we do? How do we monitor for kidney injury? Well, our kidney produces urine. So if we're checking input and output and we see a marked decrease in urine, we know something's going on. We can also do blood tests for BUN, blood urea nitrogen, and creatinine, which can then help us figure out if the kidneys are not doing well. And then we may encourage patient to drink lots of fluid. That's always good. Okay. And then again, we may have hepatitis, liver itis, inflammation. And again, monitoring and assessment of liver. It's the big thing that we do with this one. Okay. And if there's any issue, we call up the provider. Okay. So that would be allopurinol used to decrease production of gout, used to decrease production of uric acid and prevent an acute attack from happening. Well, is there another way to do it? Well, remember, so you can decrease the production of uric acid. You can also do another thing. You can increase the excretion of uric acid. So who excretes uric acid? It's the kidneys in the urine. Okay, so if we have to decrease uric acid in the blood, right, we have to increase excretion of uric acid in the urine, right? So if I have a drug that helps me excrete more of uric acid in the urine, hey, I am gonna be gold. That's gonna be another way to do it. And I have a drug that does exactly that. Probencid. Probencid increases the excretion of the uric acid. Okay. How does it do that? It's a very interesting concept. So here I have, this is my nephron. So remember you have your nephron So you have your Bowman's capsule, right? Then you have your right loop family distal tubule and then collecting duct, right? So that's sort of what a nephron looks like. The blood comes in, goes out, there's filtration that's going on, and that's going through the tubules, and some of the stuff gets reabsorbed back into the blood. So again, now we zoom this part. Okay, so you have the proximal tubule. This is where the urine is flowing. Okay, and then you have a blood vessel next to it. So what usually happens? Well, your urate gets filtered. Urate is in green, and then it gets absorbed in the blood vessel while it's going through the proximal tubule. And that absorption is reabsorbed because it was already in the blood. It was absorbed in the blood. Then it was expelled out of the blood into the urine in the proximal tubule in the nephron, and then it got reabsorbed by the blood. Okay, so that's usually what happens. Okay, now I can give Probencid. Okay, and what does Probencid do? So Probencid is in blue. Okay, so the Probencid attaches to this space, this channel, and makes this channel smaller. Okay, now it makes this channel smaller so that urate crystal is not able to get absorbed back into the blood vessel. Okay? So that urate, because it's not absorbed into the blood, gets excreted into the urine because it's not reabsorbed. Aha, perfect. Now I'm able to use Probencid and block the transporter from reabsorbing the urate crystal back into the blood vessel, thus excreting it more in the kidneys. Okay. All right. Now it makes this channel smaller. Okay. So what does that mean? And that this brings us to a very interesting, kind of a confusing concept, but I'm going to simplify this. And that's the goal in all of this is you can learn receptors and you can become PhDs in a bunch of this stuff and study this for years and years and years. But what is it that's going to help you learn this and understand this and just get an overall idea of what it is? Okay. And that's what I'm here to share with you is to give you kind of a theoretical basis for what's going on. So remember we had the channel, we had this big urate crystal, and it was able to fit through the channel and move through the channel. And then we had the next one, and we had the next one. Okay? So again, it was a very busy channel. So I may be taking some drugs. Let's say I'm taking penicillin. So just as with the uric acid, I'd get penicillin and urate filtered in my nephron. And it's going to go through my tubules, go to my proximal tubule. And when it comes to urate, this channel is pretty busy. So the urate is going to get absorbed and this channel is going to be busy. So the penicillin will not have space to go through and it will just go through and go into the urine. Okay, life is good. That's what normally happens. Well, this is what's interesting. If I give Probencid, part of this channel is taken up. So here's the deal. My big urate crystal is not able to go through. So it just goes and gets peed out. But some of these drugs that are smaller can go through here. And now because the urate crystals are not crowding this channel, there's more space for these other drugs to go through. And again, this is a very simplified way of thinking through this because the other mechanism, the what is happening at a molecular level, is confusing sometimes. But what happens is when we give Probencid, it promotes the excretion of urate, but it enhances the reabsorption of some other drugs into the blood. Well, these drugs were meant to be peed out. Well, now they are reabsorbed by the blood and they do not get peed out, which means the level of these drugs get higher in the blood when you're giving Probencid. Okay? So remember this. This is the part that's interesting. I give Probencid, the uric acid gets excreted more in the urine, but some drugs get reabsorbed more by the blood. Okay? Leading to their levels rising in the blood because they're not peed out. Okay? We'll talk a little bit more about it. So, in short, Probencid does what to uric acid? Prevents reabsorption of the urate in proximal tubule of nephron in the kidney. Ooh, those are big words. But now you understand what they mean, right? What is it used for? Chronic management of gout. So you know what it is used for, how it works. Okay? How do you know it's working? I go back to the same thing. Number of acute attacks, they're going to go down. Uric acid in the blood will go down. What if I get uric acid, and this is just a hypothetical question. What if I check somebody's urine for urine uric acid levels or urine urate? It's going to be higher, right? If the drug is working. Excellent. See? It's amazing. You're doing critical thinking. Ooh, scary. Side effects. So what was the most important thing we talked about? One of the most important things we talked about with physiology, drug interaction. Remember some of those drugs that were able to get reabsorbed very, very quickly and much in a higher amount into the blood because of Probencid? Yes, that is actually one of the issues with this one. This is a very important concept, and a lot of times I see this on questions. So I have some of these drugs that I'm giving, and we'll go through these drugs, and suddenly their levels are going to become high, even though you don't change the dose because you're giving Probencid. So this would be a drug-drug interaction. What are these drugs? This is how I remember it. I have the antibiotics, the penicillins and the cephalosporins. These are both antibiotics. I have the antivirals, which is acyclovir and gan acyclovir. I have the NSAIDs, lorazepam, and methotrexate. So these are some of the more important drugs whose levels go high. Okay? When we are giving Probencid to the patient, even though you don't change the dose. So the provider, when we are giving Probencid with these drugs, the provider may choose to decrease the dose of these drugs than they would, or would alter the timings to where we're not dosing them as much because of Probencid's effect on increasing the levels of these drugs. So if we give them lesser drug, the levels would uh, be in the therapeutic range and not in the toxic range. Okay. Again, we have headache, dizziness, rash. As with everything else, everything can give us headache and dizziness and rash. There's a rare side effect. If you have increased urate in the urine, right, that may lead to deposition or crystallization of this urate and formation of uric acid kidney stones, right? So again, when you're giving this drug, there is a rare side effect that makes complete logical sense, which is that you may have increased kidney stones related to this drug, okay? So that actually concludes our information session on these drugs. Let's go through it together one more time. So anti-gout drugs. Remember we talked about drug for acute episode. We talked about colchicine, and what it does is it prevents these WBCs from migrating into the joint and then also decreasing the phagocytosis, which causes inflammation and pain. And the goal of acute episode is what? Hey, I gotta manage the pain. Okay. So again, it's used for treatment of acute gout. How do I know it's working? Hey, pain's gonna become less. Okay. And side effects, the big one was what? Diarrhea. They have a couple of other ones. For the prevention of the acute attack, um, what do we do? That's the second classification of drugs. Okay. And this is used in the non-acute episode or non-acute attack or in the chronic phase, and the goal is to prevent the acute attack. Well, we can do that by decreasing the uric acid in the blood, which leads to decrease in acute attack. And how can we do that? There's two big ways of doing it. One is, hey, can I decrease the production of the uric acid? Two is, can I excrete more of the uric acid? You decrease the production of the uric acid by allopurinol. What does it do? It inhibits xanthine oxidase, which prevents purines from becoming uric acid. How do you know it's working? Well, uric acid levels are going to be down and acute attacks are going to be down in terms of the number of acute attacks. So what are the side effects? Hypersensitivity, renal injury, and hepatitis. Okay, and then we talked about Probencid, which increases excretion of uric acid. Okay, and how does it do that? Well, uric acid goes through the proximal tubule and gets absorbed back into the blood vessel. Probencid uh, attaches to that channel and makes that channel smaller. And that's the way I think about this. Prevents the uric acid from going in and getting reabsorbed. And so it gets peed out in our urine. And because of this, you're going to have high excretion of uric acid, decreased uric acid levels, decreased acute attacks, and you would know how it's working. The other interesting thing is that making the channel smaller, it allows some of the drugs to get reabsorbed more because now there's more space for those drugs to go through and get reabsorbed because urate is out of the way. And so you have antibiotics such as penicillin, cephalosporins, antiviral like acyclovir and GAN acyclovir, NSAIDs, lorazepam, methotrexate are some of the important drugs that get reabsorbed more. When they do, their levels in the blood rise. And so this is a very, very important drug-drug interaction that it increases levels of some drugs. Now that you know that, what do you think you would do? As a nurse, we monitor as a healthcare provider, we monitor for the side effects or toxic effects of those medications. The provider may choose to decrease the dosage or alter the dosage of these drugs when we're giving it to the patient and they're given lower doses than usual, just because we want to make sure the drug levels in the body remain therapeutic and they don't become toxic because of Probencid's propensity to increase their levels in the blood. Of course, there's a rare chance that the increased urate in the urine may cause uric acid kidney stones by the urate precipitating. So again, that's the second uh, side effect that one may have.